Today, we will discuss hyperprolactinemia, one of the most common endocrine disorders encountered in clinical practice. It is a disorder characterized by excess secretion of prolactin, which mainly affects the reproductive system but may also produce neurological symptoms if caused by a pituitary tumor. Definition: hyperprolactinemia is defined as an abnormally elevated concentration of prolactin in the blood. Prolactin is a peptide hormone secreted by the lactotroph cells of the anterior pituitary gland. Its principal physiological function is to stimulate mammary gland development during pregnancy, initiate milk production after delivery, maintain lactation during breastfeeding. Unlike most anterior pituitary hormones, prolactin secretion is primarily under inhibitory control. Normally, the hypothalamus secretes dopamine, which travels through the hypothalamo-hypophyseal portal circulation to the anterior pituitary and continuously inhibits prolactin secretion. Therefore, anything that reduces dopamine action or increases lactotroph activity can lead to hyperprolactinemia. Epidemiology: hyperprolactinemia is the most common cause of hormone hypersecretion from the pituitary gland. It is considerably more common in women, particularly during the reproductive years. This is because women usually develop symptoms early, including amenorrhea, infertility, galactorrhea. These symptoms prompt early medical evaluation. In contrast, men often have less obvious early symptoms such as decreased libido, so diagnosis is frequently delayed until the tumor has enlarged. Microprolactinoma versus macroprolactinoma. Pituitary adenoma are classified according to size. Microadenoma, less than 10 mm. Much more common. Usually presents because of hormonal symptoms. Rarely causes compression symptoms. Macroadenoma, 10 mm or larger. More common in men because diagnosis is often delayed. Produces both hormonal symptoms and pressure effects. Pituitary incidentalomas. Autopsy studies and MRI studies show that approximately 10% of healthy individuals may have very small pituitary microadenomas without any symptoms. These lesions are called pituitary incidentalomas because they are discovered incidentally during imaging performed for unrelated reasons. Most remain clinically insignificant. Causes of hyperprolactinemia. The textbook summarizes the causes using the mnemonic, the P's. Let's discuss each one. 1. Pregnancy. Pregnancy is the most common physiological cause. During pregnancy, estrogen levels rise markedly. Estrogen stimulates proliferation of lactotroph cells. The anterior pituitary enlarges. Prolactin secretion increases progressively. Although prolactin levels become very high during pregnancy, milk production does not occur because high estrogen and progesterone inhibit lactation. After delivery, estrogen and progesterone fall rapidly, allowing prolactin to initiate milk secretion. 2. Prolactinoma. A prolactinoma is a benign pituitary adenoma arising from lactotroph cells. It secretes prolactin autonomously, independent of normal hypothalamic regulation. It is the most common functioning pituitary adenoma. The higher the prolactin level, the greater the likelihood of a prolactinoma, particularly a macroprolactinoma. Large tumors may compress nearby structures, producing headaches and visual disturbances. 3. Physiological causes. Besides pregnancy, several normal physiological situations increase prolactin secretion. These include sleep, emotional stress, physical exercise, sexual intercourse, breast or nipple stimulation, lactation. These elevations are usually temporary and require no treatment. 4. Polycystic ovary syndrome. Women with polycystic ovary syndrome may have mild hyperprolactinemia. The exact mechanism remains uncertain. Importantly, the prolactin elevation is usually mild. If prolactin is markedly elevated, another diagnosis such as a prolactinoma should be considered. 5. Primary hypothyroidism. This is an important secondary cause of hyperprolactinemia. Under normal physiological conditions, the hypothalamus secretes TRH, thyrotropin-releasing hormone, which stimulates the anterior pituitary gland to release both TSH, thyroid-stimulating hormone, and prolactin. In primary hypothyroidism, circulating thyroid hormone levels decrease. As a result, the normal negative feedback on the hypothalamus and anterior pituitary is reduced, leading to increased secretion of TRH. The elevated TRH levels stimulate the anterior pituitary to produce higher amounts of both TSH and prolactin. Consequently, untreated primary hypothyroidism may present with hyperprolactinemia. Treatment with levothyroxine restores normal thyroid hormone levels, re-establishes negative feedback, reduces TRH secretion, and usually returns prolactin levels to the normal range. 6. Drugs. Many drugs can cause hyperprolactinemia. The most common mechanism is dopamine receptor blockade. Under normal physiological conditions, dopamine inhibits prolactin secretion from the anterior pituitary. When dopamine receptors are blocked, this inhibitory effect is lost, allowing prolactin secretion to increase. Common examples include phenothiazines, which are antipsychotic medications; metoclopramide, which is used as an antiemetic and prokinetic agent; domperidone, which is also commonly used as an antiemetic. Because these medications block dopamine receptors, they frequently cause an elevation in prolactin levels, resulting in hyperprolactinemia. Clinical features. The clinical manifestations result from two major mechanisms: excess prolactin itself, compression by a large pituitary adenoma. Why does excess prolactin cause reproductive symptoms? Elevated prolactin levels suppress the secretion of GnRH, gonadotropin-releasing hormone, from the hypothalamus. As a result, the anterior pituitary releases lower amounts of LH, luteinizing hormone, and FSH, follicle-stimulating hormone. The reduction in LH and FSH impairs normal gonadal function, leading to hypogonadism, infertility, and sexual dysfunction. Therefore, most of the reproductive manifestations of hyperprolactinemia are caused by suppression of the hypothalamic pituitary gonadal axis, rather than by the direct effects of prolactin itself. Clinical features in men. Men commonly develop loss of libido, usually the earliest symptom due to testosterone deficiency; erectile dysfunction. Reduced testosterone impairs erectile function; impotence. Patients may become unable to achieve or maintain erection; infertility, due to reduced gonadotropins and impaired spermatogenesis. Although not listed in the textbook table, infertility is a common clinical consequence. Galactorrhea. Milk secretion is rare in men because male breast tissue is poorly developed. Clinical features in women. Women with hyperprolactinemia usually present earlier than men because menstrual disturbances develop early in the course of the disease. Amenorrhea. Elevated prolactin levels suppress ovulation by inhibiting the hypothalamic pituitary gonadal axis. In the absence of ovulation, normal menstrual cycles cease, resulting in amenorrhea. Galactorrhea. Galactorrhea is the production of milk in the absence of pregnancy or breastfeeding. Milk secretion may occur spontaneously or may be elicited only by nipple compression. Reduced libido. Decreased libido results from estrogen deficiency secondary to hypogonadism, which develops because of suppressed gonadotropin secretion. Infertility. Suppression of ovulation makes conception difficult, making infertility one of the most common reasons women with hyperprolactinemia seek medical attention. Mass effects. Macroadenomas enlarge beyond the sella turcica. They compress surrounding structures. Headache. Occurs because the expanding tumor stretches the diaphragma celli. Visual field defects. The optic chiasm lies directly above the pituitary gland. Compression produces the classic visual defect. Bitemporal hemianopia. Patients lose peripheral vision in both eyes. Cranial nerve palsies. If the tumor extends laterally into the cavernous sinus, cranial nerves 3, 4, 6, V2, and V may be affected. Patients may develop diplopia, ophthalmoplegia, facial sensory loss. This usually occurs only with very large macroadenomas. Long-term risks. Persistent hyperprolactinemia leads to chronic hypogonadism, resulting in prolonged deficiency of estrogen in women or testosterone in men. These sex steroids play a crucial role in maintaining normal bone remodeling and preserving bone mass. When sex steroid levels remain low, osteoblastic activity decreases, causing bone formation to decline while bone resorption continues. Over time, This imbalance leads to progressive bone loss and a reduction in bone mineral density, BMD. As bone density continues to decline, patients may develop osteopenia, which can progress to osteoporosis if left untreated. Consequently, individuals with long-standing hyperprolactinemia are at an increased risk of fragility fractures, highlighting the importance of early diagnosis and appropriate treatment. Diagnostic tests and management of prolactinoma. The diagnosis is based on laboratory confirmation of elevated serum prolactin, identification of the underlying cause, MRI evaluation of the pituitary gland. Diagnostic tests. 1. Serum prolactin level. The first investigation in any patient suspected of hyperprolactinemia is the measurement of serum prolactin concentration. Prolactin levels often correlate with the size of the prolactinoma because larger tumors usually contain more lactotroph cells capable of secreting prolactin. Interpretation of prolactin levels. Less than 1000 μl. The textbook states that levels below 1000 μl are likely drug-induced. This is because many medications interfere with dopamine, removing its inhibitory effect on prolactin secretion. However, remember clinically that other conditions can also produce mild elevations, including primary hypothyroidism, chronic kidney disease, liver disease, pregnancy, stress, chest wall stimulation. Therefore, drug-induced hyperprolactinemia is only one possible explanation. 1000–3000 μl. This range raises suspicion for a microprolactinoma. A microadenoma measures less than 10 mm in diameter. Because the tumor is small, the number of prolactin-secreting cells is limited, producing moderate elevations. However, prolactin values overlap considerably with other causes of hyperprolactinemia, so MRI is necessary for confirmation. More than 3000 μl. Levels above 3000 μl strongly suggest a macroprolactinoma. Macroadenomas measure 10 mm or more. These tumors contain a much larger mass of lactotroph cells, producing markedly elevated prolactin concentrations. Large tumors may also produce symptoms due to compression of surrounding structures, including headache, visual field defects, especially bitemporal hemianopia, cranial nerve palsies, rare, hook effect. This is one of the most important concepts in endocrinology. Normally, laboratory immunoassays detect prolactin by forming a sandwich between two antibodies. When prolactin concentration becomes extremely high, the antibodies become saturated. Instead of forming the proper antibody-antigen-antibody complex, each antibody binds separately to prolactin molecules. As a result, the analyzer detects fewer complexes and mistakenly reports a low prolactin level despite the patient actually having extremely high prolactin. This phenomenon is called the hook effect. Clinical clue. Imagine a patient with a giant pituitary tumor on MRI. Serum prolactin only mildly elevated. This combination should immediately raise suspicion for the hook effect. Solution. The laboratory repeats the assay after serial dilution of the serum. Dilution reduces antigen concentration, allowing proper sandwich formation and revealing the true prolactin level. For a more detailed explanation of this phenomenon, see the link in the pinned comment below the video. Other investigations. Thyroid function tests. Always evaluate thyroid function. Primary hypothyroidism causes increased secretion of thyrotropin-releasing hormone, TRH. TRH stimulates not only TSH secretion but also prolactin secretion. Therefore, untreated hypothyroidism may produce hyperprolactinemia. If hypothyroidism is corrected, prolactin often returns to normal. Renal function tests. Prolactin is metabolized and cleared mainly by the kidneys. In chronic kidney disease, prolactin clearance decreases. Serum prolactin accumulates. Therefore, renal impairment should always be excluded before diagnosing prolactinoma. MRI of the pituitary. MRI with gadolinium is the imaging study of choice. MRI provides information regarding tumor size, tumor location, invasion into surrounding tissues, compression of the optic chiasm, relationship to the cavernous sinus. Treatment. Treatment aims to normalize prolactin, restore fertility, restore gonadal function, shrink the tumor, prevent neurological complications. Dopamine agonists. These drugs are considered the first-line treatment. Since dopamine naturally inhibits prolactin secretion, dopamine agonists mimic dopamine. They bind to D2 receptors on lactotroph cells. Activation of these receptors inhibits prolactin synthesis, inhibits prolactin release, causes apoptosis and shrinkage of tumor cells, restores normal pituitary function. Cabergoline. Cabergoline is currently the preferred drug. Advantages include high affinity for D2 receptors, produces potent suppression of prolactin secretion, long half-life. Therefore, it is taken only once or twice weekly, improving compliance. Better efficacy compared with bromocriptine. Greater prolactin normalization, greater tumor shrinkage, higher remission rates, better tolerability. Patients experience fewer side effects such as nausea, vomiting, orthostatic hypotension. Bromocriptine. Bromocriptine is an older dopamine agonist. It is still effective but has disadvantages. Short half-life, only several hours. Therefore, patients usually require 2 to 3 doses daily. More adverse effects. Common side effects include nausea, vomiting, dizziness, orthostatic hypotension, fatigue. Nevertheless, bromocriptine has the largest body of evidence supporting fetal safety, making it the traditional drug of choice if treatment must continue during pregnancy. Surgery. Medical therapy controls most prolactinomas. Surgery is reserved for drug intolerance, drug resistance, acute visual compromise, pituitary apoplexy. The standard procedure is transsphenoidal pituitary surgery. Radiotherapy. Radiotherapy is rarely required. Indications include aggressive tumors, persistent disease after surgery, resistance to dopamine agonists, recurrent tumors. Radiotherapy acts slowly, sometimes taking years before prolactin levels normalize. Management during pregnancy. Pregnancy alters prolactin physiology dramatically. Estrogen stimulates lactotroph hyperplasia. Consequently, the pituitary gland normally enlarges during pregnancy. Women with prolactinomas therefore require close monitoring. Before pregnancy, treatment with dopamine agonists shrinks the adenoma. Large macroadenomas may require surgery before conception to reduce the risk of enlargement during pregnancy. During pregnancy. Once pregnancy is confirmed, dopamine agonists are usually discontinued. The patient should be monitored clinically rather than biochemically. Symptoms suggesting tumor enlargement include progressive headache, blurred vision, visual field defects. Why is prolactin not monitored? During pregnancy, prolactin rises physiologically. Its concentration no longer reflects tumor activity. Therefore, serial prolactin measurements are not useful. MRI. MRI without gadolinium is performed only if symptoms suggest tumor enlargement. Gadolinium is avoided unless absolutely necessary because it crosses the placenta. Breastfeeding. Breastfeeding is generally safe. Dopamine agonists suppress lactation, so they are usually restarted after breastfeeding unless tumor enlargement or symptoms require earlier treatment. Cabergoline versus bromocriptine. Mechanism of action. Cabergoline. Selective D2 dopamine receptor agonist. Bromocriptine. Agonist at D2 receptors, with additional activity at other dopamine receptor subtypes. Half-life. Cabergoline. Long half-life. Usually administered once or twice weekly, improving compliance. Bromocriptine. Short half-life. Requires multiple daily doses. Effectiveness. Cabergoline is more effective in reducing prolactin. More effective in shrinking pituitary adenoma. Better tolerated. Pregnancy safety. Bromocriptine has more extensive pregnancy safety data, making it the traditional first choice when treatment during pregnancy is required. Cabergoline also appears safe based on available evidence, but long-term pregnancy experience is less extensive.